Good afternoon, everybody. Thank you for the invitation to be here with you. We are going to discuss the issue of long-acting antipsychotics, which is a very old development, but still it's underutilized in everyday clinical practice. Now, this is my conflict of interest. I have received several grants and support by the pharma industry. Now, the basics concerning schizophrenia is that it's a devastating disorder. It starts with the pre-morbid phase and progresses through relapses, eventually to a state where disability predominates and negative symptoms are those who are dominant in the clinical picture. And of course, we have some brain loss and brain atrophy with ventricle enlargement and also loss of the neuropil. What drives our clinical instinct and our clinical observation is this loss of functioning and this devastating disability, and we miss something which is much more relevant in medical terms. That's survival. People with schizophrenia die far more often than normal people, than healthy people. They have something like 15 to 20 years of loss of life expectancy. And this loss of life expectancy, this mortality rate is far higher in the younger group in comparison to older groups. This is a big issue for schizophrenia, often disregarded and neglected by the average clinician. The recovery rate is rather disappointing. Meta-analysis suggests that the recovery rate is something like 13%. There is a large heterogeneity in the literature. Some papers suggest close to 20%, other papers as low as 6%, depends on the chronicity of patients, depends on the date and the year of the study. Older studies tend to report higher remission rates, probably because the definition of schizophrenia was different. But anyway, the recovery rate is something like 13 to 15%, no better. And it does not seem to have been improved with the introduction of antipsychotics over the years. And this is very, very disappointing, very pessimistic. The biggest problem seems to be treatment adherence. And this is what the Katie study mostly found. The Katie study is a well-known pragmatic study conducted in the US, and what most people who present this study and were not part of it suggested that this is how net medication act when you don't utilize psychosocial intervention, and this is a big mistake. The Katie researchers utilized every psychosocial tool they had in their hands, like family intervention, like CBT, whatever they could to enhance adherence and to enhance people functioning. And what was the outcome? The outcome was that something like 3/4 of patients dropped out of treatment within 1.5 years. And the most pessimistic, the most dark side of this discontinuation was that 30% was patient decision without any rational explanation. It's just that patients decided to drop out treatment. And this is the biggest problem we face, as it seems that adherence, and especially partial adherence is more devious than full lack of adherence, because it's much more difficult to trace and to deal with. So partial adherence increases with time and climbs up to 75% within 2 years. So what happens is that most of our patients are not adequately adherent to treatment. And it is very difficult to assess adherence because patients tend to over-report their good behavior. If we count pills, we will see that only 10% are fully adherent. And when the patient self-report how they deal with their medication, it seems that almost all of them are very, very good patients. 2/3 are fully adherent. This is a great difference, 50% or more, 60% almost, in real and in self-reported medication adherence. And this is one of the biggest problems we face with antipsychotic treatment and one of the biggest, most important factors which determine the outcome in schizophrenia. And what happens when there is partial adherence or intermittent treatment? Well, it seems that almost 94%, almost all patients, this is an phrasing, but anyway, it seems that more than 90% of patients will eventually relapse under inadequate treatment within a year or two. More than 90%. There are some patients, approximately 10% or less, who might do well no matter what the treatment they receive or they do not receive is, but 90% will relapse. And relapsing, as I said, leads to worse outcome, worse disability, and higher mortality rates. And here comes the second empirical study from the UK, the second pragmatic study, the CATLAS, the Cost Utility and Latest Antipsychotic Drug in Schizophrenia study, which suggested that first generation antipsychotics do not differ from second generation antipsychotic. But when you see very, very carefully the results, you can see that from all treatments, if you compare baseline and after 1 year, what happened was that when they used depot injectable agents, this was the only group with increased numbers after 1 year. And they used only first generation depot injectables. This was the group that made the difference. Essentially, the conclusions was that first generations do not differ from second, but that was essentially because the study was underpowered. And if depot injectables were excluded, then second generation medication would be far better than first generation. So the depot formulation, the long-acting formulation, was the determining factor of this study. The formulation has a major impact on dropout rate. With oral treatment, we have 46% or more. With depot, with long-acting, it falls to 17%. This is a huge difference, a 30% difference in adherence. So, okay. So these compounds, the long-acting compounds, could eventually have a huge impact on adherence. Now, there are some advantages and some disadvantages with the use of these agents. The advantages overall is better controlling of the dosage, better controlling of blood levels, better controlling of the patient's attitude and patient behavior and his laboratory testing and all these. And the disadvantages are that patients might feel more stigmatized. They need to come more often to the clinical setting. They have pain at the injection site. The most important problem is that for some of these long-acting injectables, you need for some months to concomitantly use oral medication. But at any case, these are advantages and disadvantages you can utilize and you can balance in a way you can have the best outcome with the less adverse consequences. This is a short table with the available first and second generation long-acting injectables in multiple dosage formulations for the maintenance dosage. Some of them require prolonged oral treatment and some do not. Some could have acute adverse consequences like olanzapine long-acting injection. Some others are very, very safe. There is a methodological warning when we read the literature concerning long-acting antipsychotics. If we look at randomized controlled trials, in these trials, the patients who participate tend to be very, very good patients, very good boys and girls. They tend to collaborate with the therapist, so we have a ceiling effect of adherence, more or less a ceiling effect of adherence. While on the other hand, when we have pragmatic studies, when we have cohort studies, then it seems that the worst and the most refractory patients are put into these long-acting components. So in principle, you might not expect to find any beneficial effect of long-acting antipsychotics when looking at RCTs, because there is a ceiling effect of adherence, and you might not find in cohort studies because there is a big difference in refractoriness and illness severity. Now let's see what happens. Now with randomized controlled trials, we have significantly fewer relapse rates. Relapse rate is something like something like 30% lower in patients under long-acting compounds. And when we go to cohort studies, there is something close to 20% lower hospitalization rate with these compounds, and the difference seems to be mainly because of second generation long-acting injectables. If there is one study with a nationwide database, a cohort study with close to 30,000 patients, which showed a 22% lower rehospitalization with LAI. This is a huge effect, taking into consideration that, for example, statins have an approximately 10%, produce an approximately 10% reduction in the events in 5 years of treatment. And antidepressants may be 10 to 15% difference from placebo. So 22% in comparison to oral medication, it's a huge difference. For those patients who are newly diagnosed, who are younger patients in their first episodes, the difference is even higher. It's 30 to 35% lower hospitalizations. And again, second generation agents seems to make the difference and not first generation. Now, the big question is survival. Do antipsychotics improve survival? Do long-acting antipsychotics improve survival? It seems that within 5 to 6 years, in this cohort study, within 5 to 6 years of observation, 8% of patients died, and those who were not under antipsychotics had a double mortality rate of approximately 15%. Wow. Antipsychotics reduced the mortality rate for about 30%, which is again a huge reduction in mortality. And long-acting antipsychotics were significantly better in this reduction of mortality rates in comparison to oral antipsychotics. This is a summary of cohort studies with long-acting antipsychotics and survival, almost all of them from Scandinavia countries and Canada. They all consistently report improved survival rates or reduced mortality rates, depends on how you would like to call this effect, with long-acting antipsychotics and in general with antipsychotic treatment. The next question is how about the cost, because these injections are costly. They cost many times the cost of oral medication, especially since the patents have expired and we have generics with oral medication. Now, there are three main studies. One from Spain suggested that the hospitalization costs fall so much with long-acting injectables that it covers the increased cost of medication, and overall there is a 22% reduction in the total cost. All such studies suggest a reduction in the overall cost. In Sweden it is almost 8%, not 20%, but still 8%. It's a huge reduction in cost because the hospitalization rate decreases while the cost of medication increases, but the overall cost is reduced. And in Germany we have again a 21% reduction in total cost, even when the day hospital cost and other costs are taken into consideration. Again, hospitalization cost drops, medication rises, but the overall cost falls. So, in summary, schizophrenia is still a devastating disease. It is characterized by high disability rates, and we should start having in mind that the biggest problem is high mortality rates with schizophrenia. 15 to 20 years of life are lost in these patients, and many suggest that atypical antipsychotics are responsible for this high mortality rate. This is not true. Treatment with antipsychotics is significantly better in terms of mortality in comparison to no treatment at all. So antipsychotics, as an overall effect, have a protective, a beneficial effect on mortality rates. However, only 13% of patients eventually recover. And this could be because, at least partially, because of problematic adherence, which could be manageable if we use long-acting injectables. Of course, with all their advantages and disadvantages, patients may not be very eager to receive this formulation. Relatives and families might be more agreeable. Overall, long-acting antipsychotics improve relapse rates, improve hospitalization rates, improve mortality rates in comparison to oral antipsychotics, and the total cost seems also to be lower in comparison to oral compounds. Thank you very much for your attention.